This scenario is an example of a mandibular Kennedy Class 1 arch. The Class 1 arch has unbounded edentulous spaces on both sides of the arch posterior to the remaining maxillary teeth. In this particular case, teeth 20 through 29 are present. This is sometimes referred to as a 10-tooth partial. Frequently mandibular premolars are the weakest abutments. One should take this into account when designing the RPD. As always, it is a good idea to refer to the patient's existing partial, if there is one. Various other factors from the clinical examination are listed. No caries is noted, nor are there any existing restorations. The patient is not aesthetic conscious, and finances are a concern. The patient does not desire implants. The third molars will not be replaced. Areas of habitual contact are noted with articulating paper. The distance between the elevated floor of the mouth is 5 mm in the incisor area, 8 mm everywhere else. 22 and 27 are somewhat unusual for mandibular cuspids, in that they have large cingulums. 21 and 28 have guarded endodontic prognosis of unknown etiology. Assuming an intact maxillary dentition, diagnostic casts are acquired and mounted correctly. The mandibular cast is surveyed to determine guiding planes, retentive areas, areas of interference and aesthetics, as well as the position of the height of contour. No interferences to a path of placement are noted. Contours of abutment teeth are acceptable. There are no bony undercuts or frenal attachments which will interfere. The articulated casts are examined to visualize the amount of vertical space for posterior teeth and rest seat placement. Selection of abutments. 20 and 29 are the primary abutments, assuming good axial alignment, no mobility and, with no previous restorations. Short guiding planes on the distal of these teeth will define the path of insertion. These teeth will also provide retention and stabilization. The rest seat placement calls for a tripodal or quadrant support form. The primary abutments will use a mesial rest, whereas secondary abutments are best placed on the cuspids. This will allow the partial denture to maintain vertical stability in the event that the questionable first bicuspids are lost. Placement of the rest seats defines the fulcrum line. Heights of contour of the clasp supporting abutment teeth should always be adjusted so that the height of contour will be found in the middle 1/3. Heights of contour in the occlusal 1/3 interfere with optimal clasp placement. The inset demonstrates tooth surfaces marked in red which should be gently reduced to reposition the height of contour. The major connector is selected. However, examination of the patient's prior partial denture, if any, will be useful in selection of the major connector. In this diagram, the linguoplate major connector is shown. As in all mandibular major connectors, it should be rigid. It is a good idea to mark the elevated floor of the mouth to assist the technician fabricating the RPD. The linguoplate is extended to the first premolar, which will facilitate a repair of the RPD if these teeth are lost. It is very important to protect the bicuspids from movement of the framework in the horizontal plane. Resistance to this movement is provided by tall edentulous ridges and by the linguoplate anteriorly. Resistance to fulcrum line rotation is provided by well-adapted bases and the indirect retainers. Longitudinal rotation, frontal plane, is resisted by a rigid major connector. Selection of the base and retentive elements is based on the amount of vertical space present and the potential for realigning. Normally an acrylic base is used. Retention, if mesial, may be provided with wrought wire. If distal, a modified T may be used, or an I-bar if mid-buccal. The modified T provides greater frictional retention and is more efficiently located. The linguoplate, supported by cingulum rests, provides indirect retention. Tissue stops should be present on the casting, and is the only area which touches soft tissue. If not, they may be added with cold cure acrylic. This RPD has been designed to best support the primary abutments from trauma, as well as to facilitate a repair if any teeth are lost.